It's my pleasure to share with you the most updated informations and messages from new publications in the field of diabetic kidney disease. It is a very interesting topic in nephrology because it is the leading cause of end-stage kidney disease in the United States and in many countries. So today I'm going to highlight the important messages from the new publications in epidemiology presentations and trends, in the pathology and the biomarkers, different lines of management, and then to conclude this presentation. To start from China, diabetes and diabetic kidney disease is the most common cause of chronic kidney disease, according to the cause distribution of CKD in the China Kidney Disease Network, as evidenced this year. We have two types, albuminuric and non-albuminuric with reduced GFR. Here, either in type 1 or type 2, we may have albuminuric, red line, or non-albuminuric, light blue color. The dark blue color refers to microalbuminuric. All these patients progress if the GFR is less than 60 ml per minute. As you see here, there is progression of both albuminuric and non-albuminuric, and to put this in mind, to follow up diabetic patients regarding the presence of albuminuria or proteinuria or GFR. Even here, the correlation with mortality. This is the category of patients who are diabetic with tight normal albumin excretion. Here, even albuminuria is not less than 30 in A1A, it is less than 10 milligram albumin per gram creatinine. So it is tight normal. If GFR drops below 60 ml per minute, mortality increases. And mortality increases more and more if there is a progression of kidney disease toward the higher stages of chronic kidney disease. So either albuminuric or non-albuminuric, the patient's outcome is affected. Every person has his unique progression. So the pattern of GFR decline is completely different from person to another person. So this is non-progressive and this is rapidly progressive. So it is better to follow every person and to keep eye on the serial progression of kidney dysfunction. A funny data about the difference between male and female, what is known as sexual dimorphism. In the perimenopausal ladies, you'll find less prevalence of diabetic kidney disease in type 2 diabetes. Prevalence in type 1 diabetes is the same. However, in the postmenopausal period, there is increased risk of diabetic kidney disease, hyperfiltration, and end-stage kidney disease. This may be explained by the effect of estrogen, as you see here, and the reduction of estrogen plus possible increased sodium glucose cotransporter expression. All these may explain the difference between premenopausal and postmenopausal prevalence and progression of diabetic kidney disease in females. I'm going to stress upon a clinical examination, which is fundus examination, and this invites us to share with other specialties. So fundus examination is an important tool to pay attention to the pathology of diabetic kidney disease. If we have nephropathy, we can predict diabetic retinopathy, we can predict diabetic nephropathy, as shown from this systematic review and meta-analysis with sensitivity and specificity, as you see here. It is recommended to look at the eyes of the patients to know where we are. Regarding the biomarkers and the pathology, if we have a patient who presents with diabetes and coming with proteinuria or reduced GFR, we put in mind causes, different causes, infection, dehydration, immunology, etc. Then, if we have a typical history like short duration of type 1 diabetes, absence of retinopathy, nephrotic range proteinuria without progression through microalbuminuria, macroscopic hematuria, presence of red cell cast, or rapid progression of kidney dysfunction, all these are classic and typical indications for doing renal biopsy. However, the threshold of biopsy should be reduced because, as shown from Japan, that both non-proteinuric and proteinuric phenotypes in diabetic kidney disease are associated with the histopathology of diabetic nephropathy. The same here, this is the biopsy for diabetic deceased donors, and the histopathology confirmed, the biopsy confirmed the presence of histopathology for patients who are, for persons who are clinically quiescent before brain death. So, diabetic kidney pathology can precede clinical diagnosis. And this increase the attention toward reducing the threshold for doing biopsy for these patients. As you see here, the second basement membrane, mesangial expansion, and arterial cyanosis are there. So the question, should we use biomarkers? This is one of the studies confirmed that there is a value for urinary biomarkers to predict renal progression and type 2 diabetes, either the NGAL, kidney injury molecule 1, urine angiotensinogen. All these can help in prediction of the prognosis. We have many types of biomarkers, either biomarkers denoting inflammation, like all of these, fibrosis, angiogenesis, endothelial dysfunction, mineral metabolism, and tubular injury. Although they are so many, exciting, but up to this moment, there is no agreement about their clinical value, so they are not accredited for the clinical purposes. And what we still have up to this moment is to look at the urine examination and to calculate estimated GFR for follow-up of these patients. Some important messages regarding total bilirubin. Serum bilirubin is one of the defense mechanisms against oxidative stress. This is why if we have an adult with low normal bilirubin and he is diabetic, we may predict that there is increased oxidative stress for this person, and the risk for diabetic nephropathy or progression of diabetic kidney disease is higher with the lower values of serum bilirubin. And this is what is seen here. The renal survival is drastically and significantly lower with low values of bilirubin. Here bilirubin is less than 7.5 micromole per liter. This means 0.44 milligram per deciliter. So the lower the bilirubin, the poorer the renal outcome. Uric acid and type 1 diabetes, as you see here, the decline in GFR above 30% increased with the higher level of uric acid, and the outcome is affected. So here, if we look at total mortality, cardiovascular events, decline in estimated GFR above 30%, albumin progression, occurrence of end-stage kidney disease. As you see here, the hazard risks, either unadjusted or adjusted, increase significantly for each of them with doubling of uric acid. So the higher the uric acid, the poorer the prognosis of diabetic person, and the high incidence of complication. So this is the hazards for total mortality: 3 folds, 2.5 folds if uric acid is doubled. Here cardiovascular events 4-fold, and the adjusted one is 2.2. The decline in GFR is 3 folds. Here the progression toward end-stage kidney disease is double-fold. Every now and then we hear about the omics, and this is a chapter about the omics in diabetic kidney disease in this textbook of diabetic nephropathy. So we have genomics, epigenomics, metabolomics, transcriptomics, and proteomics. All these refer to the biomarkers, and because we don't have we don't have the gold standard to be used in the clinical field, we are waiting the new research in this issue. One of important research done by proteomic analysis. Here in this study, they evaluated 195 circulating inflammatory proteins, and they confirmed the association between 17 circulating inflammatory proteins and the renal outcome. What about management? To treat diabetic kidney disease or diabetic nephropathy, we should follow holistic approach, addressing all risk factors: blood pressure, albuminuria, glycemic control, dyslipidemia, diet, weight, smoking, and cessation, and the physical activity encouraging. So, regarding some important points, RAAS blockade is a standard of care if the patient is hypertensive or there is albuminuria. So if there is established diabetic kidney disease, we like to use RAAS blockade. However, using RAAS blockade to primary prevent the albuminuria is not recommended. And this is maybe explained by this study, because here in type 1 diabetes, adolescent and young adults, there is no yet increase in the efferent resistance. So renal afferent to efferent is increased only in older adults of type 1 diabetes. So we don't like to use ACE inhibitors for primary prevention of albuminuria. But if the patient is hypertensive, we can use them because they are one among the first-class antihypertensive medications. If we look at RAAS blockade as a standard of care in the well-established diabetic nephropathy with hypertension or albuminuria, here this is another added statement from experimental work. We have two types of angiotensin converting enzyme. We have isoenzyme 1 and isoenzyme 2. So angiotensin converting enzyme type 1 convert angiotensin 1 into angiotensin 2. Angiotensin 2 has many bad effects: inflammation, vasoconstriction, etc. But the isoenzyme 2 convert angiotensin 1 into 1 and 7, and 1 to 7 angiotensin behaves to the opposite direction of angiotensin 2. So it is anti-inflammatory and vasodilator. So what about if we combine cyclic angiotensin 1 to 7 to the angiotensin converting enzyme inhibitor therapy? This may be attractive in the future, but we are waiting further studies based on this experimental data. What about obesity? In obesity, there is increased renal sinus fat that can compress lobe of Henle, leading to increased sodium chloride reabsorption and with subsequent reduction of sodium reaching macula densa, with subsequent disturbance of tubulo-glomerular feedback with afferent dilatation and hyperfiltration. So this is one of important points that is added to our understandings and to combat obesity for the sake of the welfare of the patients. Another study shows that if there is weight gain at the age of 20, this increases the risk of the future occurrence of diabetic nephropathy based on this study from Japan. The diet, we should encourage DASH. DASH means diet approach to stop hypertension pattern. And as you see, if we increase the score of DASH, the risk of diabetic nephropathy that progresses to end-stage kidney disease is reduced. The lower the DASH, the higher the risk of end-stage kidney disease. How to know the DASH target? These are the nine types of nutrients. The percentage of saturated fat, total fat percentage of energy, protein percent of energy, cholesterol, fiber, magnesium, calcium, potassium, and sodium. For each one of them, there is a target and there is intermediate target. If the person consumes or achieves the target, the person is offered 1 point. If he achieves the intermediate target, he is offered half point. We like the total score to be above 5. So the higher the score, the better the outcome, and the lower the risk of development of end-stage kidney disease. So we should encourage reduction of salt, increasing fruits and vegetables because they are rich of potassium and fibers, especially in the early stages before the development of advanced stages of CKD, and we become afraid of hyperkalemia. Regarding glycemic control, in the early beginning of diabetic kidney disease with preserved GFR, our target is to intensify the treatment of hyperglycemia because hyperglycemia is a factor for progression of diabetic kidney disease. But later on, with advanced stages of chronic kidney disease, we are afraid of hypoglycemia. So our target is to change it from the intensive control toward just avoiding hypoglycemia. So we can accept 7 glycated A1C. If the patient experiences hypoglycemic episode, we relax 7.5 up to 8 or even 8.5 so long as there is episodes of hypoglycemia, because hypoglycemia may be fatal. So early, we like A1C to be less than 7%. Later, with advancement of chronic kidney disease, we may prefer a relaxed style of glycemic control. Legacy effect. What's meant by legacy effect? This means that proper control of diabetes with the early diagnosis is associated with effect that persist for life on the macrovascular, microvascular, and even mortality. But this is the effect on microvascular, macrovascular, and mortality. But this is a very nice, very recent article about the intensive glucose control among this cohort of patients with 15-year follow-up. This study shows that there is no legacy effect. The question is there legacy effect or not based on this study? The answer, yes, there is a legacy effect. The legacy effect is there if we diagnose diabetes earlier and to behave earlier. Because in this group of patients, diabetes was long-standing, and so the pathology occurs. So the secret of success is to start the treatment earlier after immediate, and this increase the trend toward screening for diabetes, especially in risky groups. Regarding antihyperglycemic drugs, this is a nice slide confirming that all antidiabetic drugs may have beneficial and renoprotective effect except sulfonylurea. There is no evidence of renoprotective effect. All other drugs either directly or indirectly have some beneficial effects on albuminuria. About metformin, we like metformin, and the data are encouraging because this is a very cheap drug, not expensive. However, it's associated with strong beneficial outcome studies. So here metformin use and the cardiovascular events in patients with type 2 diabetes and chronic kidney disease, as you see, death, cardiovascular death, and occurrence of end-stage kidney disease is significantly reduced by using metformin. The most important barrier for metformin is the lower GFR, because we cannot recommend metformin usage below 30 milli per minute. Although some experts used this drug with advanced stages of CKD, very small dose and with meticulous follow-up, but the recommendation below 30 milli per minute metformin should be discontinued. Regarding sodium glucose cotransporter 2 inhibitors, I think one of the landmark studies that was published last month is the credence that give more credence for sodium glucose cotransporter 2 inhibitors for patients with diabetic nephropathy. It is double-blind randomized trial. We have here 2,000 in each arm, canagliflozin versus placebo, and GFR is above 30, so the drug is used so long as GFR is above 30 milli per minute, and albuminuria ranges from 300 milligram per gram up to nephrotic range. So the results were fascinating regarding efficacy, either primary, composite outcome, doubling of serum creatinine, end-stage kidney disease, renal, the secondary outcome including cardiovascular death, hospitalization for heart failure. All these outcomes are in favor of the use of canagliflozin in these patients with established diabetic nephropathy. So the results were fascinating and magnificent, to the extent that the study is prematurely terminated, and this is one of the few studies that are prematurely terminated due to beneficial effect of the drug. However, if we use the drug, we should monitor the patient, because as you see here, diabetic ketoacidosis increased. Here in the canagliflozin, it was 2.2 per thousand, but here is 0.2 in placebo. So these to be put in mind. This is another member of the sodium glucose cotransporter inhibitor that was assessed in a phase 3 randomized double-blind placebo-controlled multi-center multinational in 54 investigational sites in the United States, Spain, France, and Japan, using pixagliflozin in diabetic kidney disease stage 3A to 3B. 3B means less than not less than 30 milli per minute. So 3A from 60 to 45, and this from 45 to 30. So above 30 milli per minute, the drug was efficient in reducing albuminuria. So again, this is another evidence for the effects of sodium glucose cotransporter 2 inhibitors in treating diabetic kidney disease. This may be one of the mechanisms, anti-inflammation, as shown here, with reduction of TNF. And this is another analysis for the EMPA-REG outcome trial, indicating that empagliflozin may assist in preventing the progression of chronic kidney disease, irrespective of the use of medications that alter intrarenal hemodynamics. These are ACE inhibitor or ARBs, diuretics, calcium channel blockers, or non-steroidal. This empagliflozin is effective irrespective to any of these. However, I want to stress on the type of diuretics. We should discriminate thiazide from furosemide. Why? Because thiazides work on the distal convoluted tubule, and this is outside the tubuloglobal feedback. So I think there is no interaction between thiazide and sodium glucose cotransporter 2 inhibitor regarding the issue of tubuloglomerular feedback. But what about furosemide or loop diuretics? Loop diuretics inhibit sodium potassium chloride cotransporter in the ascending limb of lobe family, and this will increase sodium reaching macula densa. So this may interfere, so furosemide may interfere with the beneficial effects of sodium glucose cotransporter 2 inhibitors. So here I presented credence, and we are waiting EMPA kidney and DABA-CKD and other trials, and the IMPA kidney and DABA-CKD are interesting because in this study we are waiting the effect of DABA in patients who are diabetic or non-diabetic with CKD. So if these studies are terminated by positive effects, this will be an adding and bonus points for the use of sodium glucose cotransporter 2 inhibitors. Now, to use this class or not, what is the evidence-based medicine or the critical appraisal? Yes, we like to reduce cardiovascular events and measure adverse cardiovascular events, mortality, heart failure, CKD, and NAFLD. All these are beneficial effects of sodium glucose cotransporter 2 inhibitors, but there are some risks, like genital infections, UTI. Their use with volume depletion is not recommended at all. Possible AKI, euglycemic diabetic ketoacidosis, and I'm going to stress upon these points in the following slides. Bone fracture and Fournier gangrene, TBC, to be confirmed, and amputation with canal flows. And so all these points should be put in mind. Why we should put them in mind? Because the best way is to individualize the management according to the patient demographics. So it's not wise at all to start sodium glucose cotransporter 2 inhibitors for a dehydrated person, for a patient with active genitourinary infections. So we should be careful about that. One interesting point, the effects of sodium glucose cotransporter 2 inhibitors on phosphate homeostasis. This study shows that dapagliflozin may increase serum phosphorus with subsequent increase in BTH and FGF23. So all these to put in mind for the effects on mineral bone disorders, especially in patients with CKD. And this is another review article, very interesting, addressing these points. Regarding euglycemic diabetic ketoacidosis, we should be careful about this phenomenon, because in the patients here, in this, if there is precipitating factor like intercurrent illness, infections, acute kidney injury, diet modification, especially in the pre-operative fasting, this is why before surgery, this class of drug should be discontinued completely, and there is resume after surgery should only after the patient regain his stable style of feeding. All these points should be put in mind. Why there is a risk of euglycemic diabetic ketoacidosis? Because this class of drugs reduces insulin and increases glucagon, and this phenomena hormonal changes lead to lipolysis and increased free fatty acid. One of important point, this class is associated with glucosuria and natriuresis, but increased ketone bodies reabsorption. The clinical implication of this physiological message is, if we think of euglycemic diabetic ketoacidosis, we shouldn't monitor urine, because urine may show false negative results. And if we want to test, we should test the blood for beta-hydroxybutyric acid. So this is an interesting point, because there is increased ketone bodies reabsorption. Fournier gangrene, it is devastating infection in the preanal areas, may affect men or women. And it is devastating, associated with sepsis and mortality. And these are 55 cases associated with sodium glucose cotransporter 2 inhibitor use. I cannot say this is the cause of Fournier gangrene, but to put in mind. So in a digest, we have many trials. All these trials, EMPA-REG, Canvas, Declare, TIMI, confirmed that the nephrology endpoints, renal endpoints, improved by the use of the sodium glucose cotransporter 2 inhibitors. And the Credence study added a bonus point and prematurely terminated because of beneficial effects. But we should be careful because the members of this class are used only if estimated GFR is above 30 milli per minute. And in elderly persons, we may expect nutritional deficiencies because of glucoretic effect. And although there are some studies about their use and there are ongoing trials to assess their use in type 1 diabetes, extreme caution should be exerted because in these patients with type 1 diabetes, there is increased risk of development of ketoacidosis. To just about ketoacidosis, if the patient is treated by these drugs, we should follow the patient. The patient comes with fatigue, nausea, and vomiting. We should put the possibility in our mind and just order a test for blood gases. And if there is a possible sepsis, we can order a lactate level. If lactate is negative, we should think of beta-hydroxybutyrate. If we diagnose euglycemic diabetic ketoacidosis, the treatment is IV glucose with insulin. An important message from basic research: if we use sodium glucose cotransporter 2 inhibitors, this may increase the expression of sodium glucose cotransporter 1. So increasing sodium glucose cotransporter 1 may attenuate the beneficial effect of glomerular hyperfiltration, the effects of the sodium glucose cotransporter 2 inhibitors on the hyperfiltration. So this may open the horizon for dual blockade or using other drugs. Regarding glucagon-like peptide 1 receptor agonist, this is a recent study. It is very interesting study, double-blind, randomized control trial, assessing dulaglutide, which is given sub-Q once weekly. So the number of patients in each arm is here in comparison to placebo, approximately 5,000. And here, one-third of the patients in each arm, there is albuminuria, and this is the percentage of patient with lower GFR below 60, 20%. So there is a good fraction of the nephropathy, and here there is a significant difference, beneficial effects of dulaglutide on the renal outcome. So it is maybe the time to rewind the cardiorenal clock in diabetes by the use of dulaglutide. I think this is a good additive for the treatment of diabetic kidney disease. This is the meta-analysis confirming the role of liraglutide as a member of glucagon-like peptide 1 receptor agonist. As you see here, all the data regarding albumin creatinine, urine albumin excretion, and creatinine are in the favor of the use of liraglutide. And this data also confirmed the reduction of TGF-beta, TNF-alpha, and interleukin-6, so the inflammatory biomarkers are reduced by the use of liraglutide, with additive beneficial effects on body mass index, total cholesterol, and triglycerides. And this is another study addressing the issue: is it because of reduction of body weight dulaglutide exerts a beneficial effect on kidney disease? This study confirmed that the effects of dulaglutide on the renal outcome is not related to its effects on body weight. So the dulaglutide has renal protection away or independent from body weight reduction. Is there a comparison between glucagon-like peptide 1 receptor agonist and sodium glucose cotransporter 2 inhibitor? This is a systematic review and meta-analysis addressing all the studies for GLP-1 receptor agonist and sodium glucose cotransporter 2 inhibitors. As you see here, regarding broad renal outcome, both classes are beneficial to the kidney. But if we analyze the data away from macroalbuminuria, so after excluding macroalbuminuria, the effects of sodium glucose cotransporter 2 inhibitors are impressive. This is one of the most important studies that was published early this year about the linagliptin double-blind, placebo, randomized controlled trial in 600 centers across 27 countries, and with using the linagliptin in more than 3,000 patients against placebo, and the study confirmed the safety of linagliptin, so it adds nothing regarding cardiovascular events in comparison to placebo, and more importantly, the effects on albuminuria is significantly reduced by the use of linagliptin. Regarding the class effect, is there a class effect? For DB4 inhibitors, you can find here inconsistent results, so there is no class effect. For GLP-1 receptor agonists, the same, there is no class effect, but all members in sodium glucose transporter inhibitors have the same, so there is class effect. If we put all the data together, we may reach this map for an algorithm for management of glycemic state in patients with diabetic kidney disease. We should start with lifestyle changes. This is of paramount importance. Diet and exercise and stopping smoking and salt restriction. All of these are essential. And then if estimated GFR is above 45, we can use metformin up to 1.5 gram per day. If we are in 3B, between 30 to 45 milli per minute, the limiting dose is, the metformin is limited to the dose of 850 milligram. Below 30, not to be used. Then to test for A1C and albuminuria. If there is normal to moderate albuminuria, we can use DPP-4 inhibitors. But if there is high albuminuria and the patient has heart failure, sodium glucose transporter inhibitor is highly indicated. If there is a risk for atherosclerosis, we may think of GLP-1 receptor agonist. Then we can add any of them according to the glycemic state or adding insulin. So this is a good algorithm of management of diabetic kidney disease. Regarding other drugs, one of the landmark study that is published this year is atrasentan, which is endothelin receptor antagonist. This is a unique study because they started assessing atrasentan in a tolerability study for 4 weeks to assess the volume overload and the response of albuminuria. And when there is no problem regarding volume overload and there is a reduction of albuminuria, the patients are double-blind, are subjected to double-blind randomized placebo-controlled trial. And this study showed that the atrasentan is another turning point in treating of diabetic kidney disease with better renal outcome. However, you may find some important side effects like hypervolemia, here 36% in comparison to 32%, the occurrence of anemia, and all these needs explanation. So again, this may be a turning point for chronic kidney disease. We are waiting further studies for this molecule. If we compare or look at the different outcome for the different trials, we have Renal using losartan, irbesartan, Credence, canagliflozin, Sonar, atrasentan. The comparator for Renal and irbesartan was placebo, and there is an absence of RAAS blockade. However, in Credence and Sonar, the placebo plus RAAS blockade. So we should put this in mind. So Renal and losartan and irbesartan are RAAS blockade, and here we use RAAS blockade plus canagliflozin, RAAS blockade plus atrasentan. And this is the relative risk of hazard ratio, as you see here. All the effects here. This is the effect of the different studies, and this Credence have a strong endpoint. Relative risk hazards for doubling of creatinine or end-stage kidney disease, as you see here, and the color here refers to the different studies. So, and you can fix this slide just to know that there are added points this year, especially Credence and Sonar. Americarin, it is a new direct renin inhibitor, and this study shows that this molecule is efficient in reducing microalbuminuria with, as you see here, this is the change in baseline urine albumin creatinine ratio. This is the placebo, and this is in placebo albuminuria increased by 16%, but here with amycretin, the albuminuria is reduced in a dose-dependent fashion. So it is another added tool for treating the diabetic kidney disease. Mineralocorticoid receptor antagonists. Regarding the mineralocorticoid receptor antagonists, if you look here, we have many generations. The first generation is spironolactone. We are afraid of hyperkalemia. The selectivity, it's not high selective for mineralocorticoid receptor, with some affinity to androgen and progesterone, and this may explain gonadal and gynecomastia side effects. And then we have eplerenone, second generation, and third generation finerenone. So, and we are waiting the ongoing trials of assessing finerenone in treating diabetic kidney disease. This is one of the new molecules about mineralocorticoid receptor antagonist, is a xerenone in comparison to placebo in a double blind, and this is the placebo, and this is different dosages of this molecule. As you see, the albuminuria, urine albumin creatinine ratio, is significantly reduced and in a dose-dependent fashion. But the remission is also increased in a dose-dependent fashion, and the effects on blood pressure is there. And this figure summarizes the results of the study. It's multi-center double-blind study, and this is the different concentration of the drug: 1.25, 2.5, 5 milligram in comparison to placebo, and there's a change of urine albumin creatinine ratio increased. The reduction is increased by large dose. However, if the dose is above 2.5, the risk of hyperkalemia is significant. Here it's 10% in 5 milligram. Another study for this molecule, a single arm open label for blood pressure reduction. It is also can help in reducing blood pressure, systolic and diastolic. The role of epigenetic methylation and effects and altered gene products, and all these drugs are approved for manipulating epigenetics, and we are waiting their testing in the future. This antioxidant reduces so AST120 can be used 6 grams per day and continued for 24 weeks, with renal function improved in 80% of patients with this antioxidant that reduces uremic toxin, hydroxyl sulfate. This is a Bacon trial that induces nuclear factor erythroid-derived 2, related factor 2, and suppresses nuclear factor kappa beta, so it's an anti-inflammatory. However, this study was premature terminated because of safety concern, largely related to a significant increase in early heart failure. However, it carries a good message. What is the good message? With the early use of this drug, bardoxolone methyl, what happened? The urine albumin creatinine ratio increased. In comparison to placebo, there is increase in albuminuria. But on the long run, there was a beneficial effect on estimated GFR. So the urine albumin creatinine ratio in the beginning increased, then reduced, but the estimated GFR is improved by the use of the drug. So increased albuminuria in the early beginning of the use of this drug, bardoxolone, may be explained by improvement of GFR. But later on, with anti-inflammatory effects, this may protect the kidney. But because of the study was prematurely terminated, we are waiting further evidence for this point. Regarding vitamin D, there is no sufficient evidence to recommend the use of vitamin D for treating diabetic kidney disease. However, if we diagnose vitamin D insufficiency or deficiency, it is maybe wise to use vitamin D. Regarding renal replacement therapy, we have hemodialysis or peritoneal dialysis. This study shows, and this is a meta-analysis of cohort studies, confirmed the beneficial effects of hemodialysis on mortality in comparison to peritoneal dialysis. If you ask me, is it HD hemodialysis or peritoneal dialysis for diabetic kidney disease? I say it is neither HD nor PD. It is transplantation if the patient is fit for transplantation. To conclude, we have many agents to be used for treating diabetic kidney disease. This color refers to agents still in the preclinical studies, like apoptosis signal regulating kinase and others, and the RAAS blockade, sodium glucose cotransporter inhibitor, GLP-1 agonist. All these are the current treatment. But the drugs working in epigenetics or apoptosis signal regulating kinase, we are waiting further results. And the most important point is we should change our mind from treating well-established diabetic kidney disease into preventing diabetic kidney disease by aggressive reduction of risk factor of diabetes to prevent diabetes from the beginning, and for early management of diabetic kidney disease by using lifestyle, RAS blockade, if there is albuminuria or reduction of GFR, or there is hypertension, controlling the lifestyle, smoking cessation, salt restriction. All these points can make a big difference. Working with diabetes in a team, this is one of the important messages, is to work with a team and with all other specialties for the welfare of the patients. To improve the research, and one of the important research that we have, this the thesis of Dr. Summer. I am honored to be the principal supervisor. So the impact of induction of autophagy, we proved in this experiment reduction of autophagy in diabetic kidney disease rat model, and we tested the manipulation of autophagy that may even reverse the pathology. And we are honored to have Professor Parsoum and Professor Sobh for the discussion of this thesis. Also, at Urology and Nephro Center, we have the team of research of stem cell research in diabetes, led by Professor Ghunaim and Professor Ayman Rifai and all other members in the team. We are waiting the results of their work, and I am sure that at certain point of time they will reach the big success. Education is of paramount importance, and a doctor is a student until he dies. Once he considers himself not a student anymore, the doctor inside him dies. Before concluding this presentation, I'd like to congratulate Professor Ata Bakr, Professor Ala Awafa, for organizing a fascinating conference about diabetes. And this was a conference of the diabetes and endocrinology unit that was held at Ramada in Mansoura. And always I'm happy to be with my colleagues, professors, and friends in all specialties, especially in diabetes. At this point, thank you very much for your attention. Goodbye.